quick overview. I'll start with this, and then I'll ask Bob to take over from there. As an organization, many people always ask us, who is Tidal Health? Who bought you? It is us. It's always been us. We just decided now that we've come together, and it's really where Peninsula Regional Medical Center and the former Nanticoke Memorial Hospital and the former McCready Hospital, as well as a host of other physician practices over the last year, came together into a new system. So we do have a foot in legacy and a foot in prophecy, but we always felt that as we look to be something new, since we've come together, we want to shed a little bit of the past, but have that legacy component to it as well. So we are Tidal Health. We just rebranded because really when we come together, we bring the best of all worlds. We didn't want one organization kind of leading the way, if you will. We are new, we're one, and we're regional based. So the decisions and the care is local here on the shore. So a little bit about us. This is a map, and I'm sorry I have to look off to the side because I'm using a different monitor to share. This is the map of where we are. We have the major hospitals in Seaford and Salisbury, and typically in healthcare systems, hospitals are the larger component of it. But what we see is as Tidal Health, really it's our physicians. We have over 250 different providers now that are employed within the health system here on the shore. And most of the push pins you see there are the doctor's offices, but it also includes a host of other elements in healthcare, like a freestanding surgical center, our integrated breast center. We have 30 total different locations of all these different types of procedures and offerings. But also we have a bunch of joint ventures because there's things we know we can't do well that others have the expertise in, like home health is a great example. So we do have all those 30 different locations across 6 different counties now on the shore. And we have over 5,000 employees within that. As I mentioned, the joint ventures. Collectively, it's actually $1.5 billion now that we've picked up a few other physician practices recently. So we are now over $1.5 billion in assets. The beauty is the organization is financially very strong from a balance sheet perspective. They've done a phenomenal job over the years to manage that. Operations are always tight in a non-for-profit world. So we live on very thin margins. The state of Maryland regulates how hospitals are reimbursed. So we don't negotiate with payers like they do in the rest of the states. So our rates are set. So all payers, Medicare, Medicaid, uninsured, it doesn't matter, all pay the same rate. So there's no offsets there. As I mentioned, the 6 different counties that we cover. The major entities are Peninsula Regional, so Tidal Health Peninsula Regional, so that is here in Salisbury. The campus has grown since 1897 when it started with Dr. Todd taking horses out to homes, and the horses got tired. So that's where the story is of the origins of how the hospital was built here in Salisbury. Then the other campus, beautifully located on the Nanticoke River in Seaford. As you can see some of the signage here, it's all been rebranded. So wherever office you go to, it is now a Tidal Health office. So we kind of make sure to show that we are together and we're better together than we are individually. The other largest component is medical partners. As I mentioned, there's over close to actually 800 employees now and over 250 providers, and they represent 23 different specialties. So if we can't provide it, and if there's tertiary level care like endovascular neurosurgery, if there's stroke care, or if there's open heart or structural heart problems, we want to make sure that the care is delivered here on the shore, and we provide those services. But even if it's something we can't do, we definitely refer to other providers where that quaternary care is delivered. As the health system name, this is kind of a neat part in the branding world. I usually have like an hour presentation. I won't do it today. I'll just do this one slide. After we came up with the name and we selected it, we went back and did some research. Nanticoke actually means tidewater people. That felt good as we were kind of deciding on this name. And if you think about the rising and lowering of tides, they're what form the Eastern Shore. So, tides are actually more consistent and more predictable than the wind and the sun. So that's where we felt as healthcare providers, we want to always be counted on. So at the indication that we'll always be here. So welcome to Tidal Health. That's kind of my quick high-level overview of who we are as an organization, and I will now, for the most part of this, turn it back to Dr. Joyner so he can talk about COVID.
All right, I'm going to see if I can share my screen here. And first question I'll ask is, can everybody see that?
Yes.
Yes, you're good.
Okay, good. So my name's Bob Joyner. Just in regards to giving a little bit of background of myself, I'm a respiratory therapist by trade. That's what the RRT and that initial means. I practiced as a respiratory therapist for about 20 years. I traveled as a respiratory therapist. I've worked in New Orleans, I've worked in Boston, I've worked in Maryland, I've worked in New Hampshire and Vermont. As a respiratory therapist, most of that spent in neonatal, pediatric, and adult critical care. The rest of those initials there, I have a PhD in physiology, although I did not study COVID or vaccines. My graduate degree is actually in physiology, where I studied something called pulmonary hypertension. Many years ago, when I was in graduate school, about 1993, there was a drug called Fen-Phen, and Fen-Phen was a weight loss drug, and it was a drug that was actually on the market for about 6 months. It caused all kinds of heart problems, that chief being pulmonary hypertension. So back then it was a popular thing to study, and that's how I got involved in that. So I'm a graduate of Salisbury University. My graduate degree is from Dartmouth Medical School, and I came back to the area in 1998. And I probably should have started this by saying that I grew up essentially in Solomon's Island, which probably some of you know. And so by rights, I probably should have been a waterman, but that actually never happened. This particular talk covers a number of topics, and it starts out pretty heavy science and then works its way into something that's more practical. I do think it's still probably important to talk about where the COVID vaccine came from. I think some people are still thinking about that idea, and it provides some influence on whether or not they want to get the vaccine or not. And so this chart is meant to show how the normal timeline of coming up with a vaccine, which was somewhere between 10 and 30 years in this past year, actually ended up being about 11 months to come up with the first vaccine for COVID-19. So how did that happen? So the difference between the normal timeline and the COVID-19 timeline was Operation Warp Speed, which essentially funded everything that it needed to fund. And so the companies that were developing vaccines who were being covered by Operation Warp Speed did not have the risk of financial loss. So essentially the federal government purchased the vaccine before the vaccine was known to work. If you got to the end of the process and the vaccine didn't work, they threw it away, and the company didn't lose money. If they got to the end of the process and the vaccine did work, because all of that had been taken care of, the process could be sped up. Under traditional circumstances, which is still the circumstances that was at work for the development of the COVID-19 vaccine, there are phase 1 trials, phase 2 trials, phase 3 trials, and then licensure. And essentially what happened as these phases of trials were going through, because the federal government was supplying the funding for this, they were already doing the large scale manufacturing. So by the time they ended up in the phase 3 trial, if the vaccine worked, and specifically for Moderna and Pfizer, it did, they already had a large amount of the vaccine available. So how does the vaccine work? And one of the things that I keep reminding people is that we are benefiting from 21st century medicine. So another factor in regards to increasing the speed of its availability is just purely by the fact that we've benefited from the past 75 years worth of science. Vaccines themselves are made up by 4 different categories. So they're viral vaccines, which are either inactivated or weakened. Think polio virus for that. In regards to replicating and non-replicating viral vectors, the non-replicating portion provides the incentive for the cell or the body to respond by building antibodies. More about that in a second. but it's not actually the virus itself. It is something that makes up a component of the virus, and that's the thing that your body responds to. In regards to the Johnson & Johnson vaccine, which is about to become available, that's a non-replicating viral vector. The Moderna and the Pfizer vaccines are referred to as nucleic acid vaccines, and they're both what is called RNA vaccines. So I'm going to pause for a second and explain that just a little bit. So DNA, it doesn't matter where you watch it, they always talk about it as being the blueprint for your body, the blueprint in regards to how things are made or what they're made up of. The RNA is actually the information that's utilized to put what the DNA describes together. So it's the functional part. That's the way you should think of it. So it's I've heard people describe it as the contractors. So the RNA gets into the cell, and the RNA is actually the specific instructions that it takes to build something inside the cell. In this particular case, it's building something called the spike protein. Hang on to that knowledge for just a second in regards to the spike protein. And then there are also a set of vaccines that are protein-based. They're both related to this spike protein, and it's essentially making up or building the spike protein and putting it inside of a person, and that's the way in which it would work. So I'm going to go back to this RNA vaccine again, and again, sort of the understanding that the RNA itself is the information that is the physical act of how do you make something. And I'm going to jump to this page for 1 second and suggest to you that this cartoon is supposed to be portraying a coronavirus. And the coronavirus, these pieces that are coming out, and by now everybody's seen the sort of wonderful pictures that people are making up, but the spikes coming outside of the coronavirus are called the spike proteins. You can envision that the spike protein is actually what the human body recognizes as foreign material, and it's what it builds antibodies and its immune defense against. So the way that the technology works is that they actually have encoded the information that it takes to build a spike protein that matches what's in the coronavirus. You take that thing that is the instructions to build a spike protein, not the virus itself, but the spike protein, you put it inside of a cell, and because RNA works with the manufacturing of the cell actually manufactures the spike proteins. So they're images of the same spike proteins that would exist on the outside of the coronavirus. But what it doesn't have is the coronavirus. It only has the spike proteins. The body recognizes those spike proteins as foreign, and because it still recognizes those spike proteins as foreign, it responds by making neutralizing antibodies. So no chance at all in regards to a vaccine giving you the COVID-19, because there is no COVID-19 in the vaccine itself. There's only the ability to produce these spike proteins. One of I undoubtedly, some of you have received the vaccine, at least I would think that some of you had, and the complaints that are associated with the vaccine are a sore arm, maybe some small fever, aches and pains, something that for about 24 to 48 hours may make you feel like that you have a spot of the flu, something like that. The reason that you have those feelings is because when your body is mounting an immune response and building those immunoglobulins, you get a fever, you get aches and pains. But within about 24 to 48 hours, you've made the antibodies, and the body is prepared to meet the coronavirus again. So the next time you're exposed to it, you have antibodies inside your body. those antibodies recognize these spike proteins. And now it's not just spike proteins hanging around, it's actually the entire molecule, and that entire molecule is neutralized. And so that's how those RNA vaccines work. In regards to the Johnson & Johnson vaccine, the way in which it works is it's not having the body build the spike proteins, it's actually taking spike proteins into the body. And the body still recognizes it in the same way and builds neutralizing antibodies against it. And so in each one of these cases, I always describe this a little bit like a car. They're all doing essentially the same thing. In one way or another, they're having the body recognize spike proteins. When it recognizes the spike protein, it builds neutralizing antibodies against it. And based on that, that's how you become resistant to COVID-19. So Operation Warp Speed itself and the way in which this worked. So the other concern that I hear from people from time to time is that they're worried about the pace at which this was built. And something that you should know is that there's at least 14 different vaccines that are being evaluated through Operation Warp Speed. You can see now the stress on the system.
Our doctorate degree.
You can see now the stress on the system that's happening because we want a tremendous amount of these vaccines, and so there's a reason to have multiple vaccines available so that we can meet the demand. What's important here is that there was no limitation in regards to the testing of these vaccines. They were tested in 44,000 people before they were approved by the FDA. And that is much larger than any other vaccine trial in history. So for example, a recent vaccine trial, which was Haemophilus influenza back in 1993, would have had many fewer than 45,000 people tested to get approval. So not only was this an effort to get a vaccine made quickly, it was also a very vigorous effort. And the effort was to have about 300 million doses available by January 2021. What's really important is that effort to get 300 million doses available, if they were only available in the United States, then that would be a good portion of the United States. But 300 million doses compared to the world's population isn't as many as, it doesn't sound like as many as it did when you think of it just for the United States. The other challenge here is that the sort of cold chain delivery of these vaccines can be complicated. One of the vaccines requires minus 80 degrees Celsius freezing, and you have to deliver two shots instead of one shot. So while the vaccines work, the delivery is complicated, and we're all waiting for a much simpler vaccine to use, like the Johnson & Johnson, which is a single vaccine that can be kept in the refrigerator up to 4 to 6 months, if I remember correctly. And so it's like everything else. The technology is improving. So the vaccines work, but the delivery of the vaccines is improving. One of the questions I get quite often is, should I wait for the newest and greatest vaccine to come out before I get vaccinated? The answer to that is no. The vaccines do work. The challenge of delivery should be left up to hospital systems like TidalHealth and the government to figure out ways to get those vaccines into people's arms, not for the people to wait for the vaccines. If you're interested in this kind of research, you can look it up on what is being run by the Operation Warp Speed, and it's called coronaviruspreventionnetwork.org. And there's lots of information there in regards to how vaccination is going. Side effects. So two things to know about side effects that are possible. One, there are some, and what I mean by that is that people can get sore arms, they can get malaise or tiredness, they can get muscle pain, joint pain, headache, and all of these things are in reference to stimulating the immune system to respond to those spike proteins. And when the immune system responds, that is what you're feeling: fatigue, muscle pain, joint pain, headache. So in some way, that reaction that you get, and even if it is severe enough, which is pretty infrequent, but even if it is severe enough to keep you out of work for a day, that is because your body's responding to the vaccine in the correct way, not because your body's responding to the vaccine in a wrong way. Lots of information gets put out in regards to what it's like to get the vaccine. I think that you have to be transparent with people in regards to that. So what you feel, what I felt a pretty sore arm, to be truthful, but it didn't keep me out of work. I do work with a number of staff, two that were asked to stay home on the following day, but by the third day, they were completely back to normal. So it goes away pretty quickly. So the feeling that you get after the vaccine, those reactions are stronger than the reactions you see with the flu vaccine, but they're not, they clear up pretty quickly. The one additional piece that I put inside this talk, because it's a conversation that's happening all of the time now, is this idea of having variants and how variants are how variants are affecting vaccine delivery. The first thing that I want to say is that all viruses constantly change. This isn't something that's mystical or voodoo-ish in regards to the SARS-CoV-2 virus. It always was expected to change, and I think that probably should be brought up more often than it is. In regards to the variants, and there's going to be more, the three that are in this talk as of February 2nd of this year were the one from the United Kingdom, the one from South Africa, and the one from Brazil. By and far, the United Kingdom variant is the one that's present in the United States. And as probably could be predicted, the variants are located mostly in places where there's a high number of COVID cases. So the COVID cases are being caused by the variant, or the variant's there because there's lots of COVID cases there, but essentially that's where the variants are. And the one slide that I'm going to have that's going to have a lot of text on it is going to be this particular slide, because I think it's important. The other thing that's important is, while everybody wants answers yesterday, today, they want answers as fast as they can get them. This is really sort of the edge of where our knowledge is right this second. In the United Kingdom, the variants known to spread more easily and quickly than other variants. The UK took a very conservative approach, and the Prime Minister came out and suggested that they didn't know, maybe the variant did increase the risk of death. What is known is that they have to do more research. I don't know that it's specifically known that the variant itself causes more deaths than other variants. So more study is needed on that finding. It was first detected in the United States in December of 2020. The South African version was first detected in the United States in 2021. In the Brazilian version, it was first detected in January of 2021. The Brazilian version is the one that people are focused on right this second, because the particular places where the changes are in the viral structure may affect its ability to be recognized by the antibodies. There is a little bit of research on that. But the questions that are left in place that people are trying to answer right this second is that we know that variants seem to spread more easily and quickly, which may lead to more COVID-19 cases. It may put more stress on healthcare resources. It may cause more hospitalizations, and potentially it could increase death. But the truth is that nobody knows the answer to that, and anyone could ask those same questions because there's no data available. What is known so far is that the studies that are available on these variants suggest that the antibodies generated through vaccination with these currently authorized vaccines do recognize the variants. So they are they do provide protection against these particular variants. And this is where the study is right this second. People should continue to protect themselves. They should continue to wear masks. They should continue to wash their hands. They should continue to distance themselves and not congregate in large gatherings. So all of those things are true, even if you got vaccinated. For the most up-to-date information, if you don't know this, it's available on the Maryland COVID link. And when I send this information out, the link will come with it. And inside of this COVID-19 vaccine link from the Maryland Department of Health, it provides a couple of things. Sorry for the small slide, but it will tell you what phase it's in. Or we're in regards to distributing the vaccine, so where the priority groups are. It's important to know that as we migrate down the priority groups, the number of people that become eligible to receive the vaccine increase. I don't know if it increases exponentially, but it certainly increases in very large ways. So you start with all of the healthcare providers, frontline hospital staff, nursing home residents, assisted living, firefighters, law enforcement, education, correctional officers, and you move on to the adults that are 65 and older, and people who have significant comorbidities and are at risk for developing severe COVID. That's where we stand right this second. So, there was a lot of emphasis placed on people who are or were resistant to getting the vaccine itself, so vaccine hesitancy. I think that's appropriate, but I also think it's appropriate to suggest that supply is currently an issue. It's not an unlimited supply. It's not an unlimited supply anywhere, and it's specifically not an unlimited supply on the Eastern Shore. So the questions that I'm receiving are, I can't get an appointment. How do I get on the list? And those are much more common questions than the questions that are related to, I'm nervous about getting the vaccine. I agree that the supply is something that's going to be an ongoing issue for a while until we get more of the population vaccinated and fewer people actually require it. The phases are broken up like this. So we've gone through 1A, which was all of the healthcare providers and first responders. We went through phase B, 1B, which included all of the assisted living and adults age 75 or over. And we're currently in 1C, which is our adults over the age of 65 and essential workers. Again, one of the things to keep in mind as you go through these groups is that it's an ever expanding larger population that's available. Certainly there are still healthcare providers that are being vaccinated. Certainly there are still assisted living and people who are age 75 and older still getting vaccinated. And then you include in those groups the large number of people who are age 65 and older. And with that, I'll pause and ask if there's any questions that myself or Chris can answer in regards to these presentations. I'm happy to answer them. hopefully that was something that you're looking for in regards to information. But like I say, if I work the vaccine clinic this afternoon, if I can help you, please let me know.
One thing I'll add to that, Bob, is the fact that, it is a supply issue, both from either the health departments down to us getting the vaccines. Now between the first and second doses, we've done over 10,000 shots. We're also over, I think it's over 400 infusions over in the antibody site as well. So for those who do have COVID with comorbidities, we also offer that service. But Bob is correct. It is a supply issue. So if we had more supply, we'd have more slots open. So the only thing we can suggest for individuals who are concerned or want the shot is to keep trying.
Yeah. And realize that it literally changed, the availability of a slot literally changes all of the time. There are people who, believe it or not, there are people who cancel their appointments. And some of that's understandable. It could be that they were able to obtain the vaccine from somewhere else, so they're being courteous by canceling their appointment. So you do definitely have to keep looking.
I do have a question. This is Jeannie with Best Temp Staffing. So is the vaccine for those individuals who have not already been infected or diagnosed with COVID?
It's actually for both.
Is
The recommendation is to, if a person has had COVID, the recommendation is to wait 90 days before they get the vaccine. The one thing that I will point out in regards to people who have had COVID, those sort of reactions that people have, a sore arm, malaise, tiredness, those sort of things seem to be heightened in people who are receiving the vaccine after they have COVID than people who are naive to COVID or have never had it. And the reason for that is because the body's somewhat amped up already because it has experienced COVID and it's ready to go. So when you give the vaccine, it's ready to go.
Okay, so those who have had COVID, there are some that had very mild, well, actually asymptomatic, very mild symptoms and or very severe symptoms. I think it's confusing.
Well, when you say symptoms, you're referring to symptoms to the COVID-19 itself, right?
Correct, but aches and pains, is a symptom. Stuffed nose, or seems like you had a sinus infection, but you tested positive for COVID.
Sure. I think that currently is what people are looking to try and understand in regards to why some people react so negatively to COVID, and COVID does have a mortality rate to it. So there are some people who react very negatively to it. That high risk group seems to be the elderly and people with diabetes and hypertension and other comorbidities, risk factors associated with that. So again, in regards to the vaccine itself, the vaccine doesn't carry COVID in it, so it doesn't have those reactions that you're talking about right this second. It only is reacting to that spike protein and building antibodies.
Okay, and then another question we have been asked from our clients in our staffing business is, will we be, I guess, mandating or writing policies to mandate and or have the COVID vaccine be voluntary? And although we don't have any vaccine flu, statement at all as a company. I guess it would all be voluntary at this point for us.
I think that's probably a personal business decision in regards to what businesses do. It's not a mandatory requirement at TidalHealth right this second. But I think there's a little bit of a caveat to that in regards to other businesses. For example, the airlines may institute policies that require someone to demonstrate that they've had the vaccine. So I think that's just something to keep in mind.
Okay, thank you.
Thank you.
And Jeannie, one thing to add to that is, as Bob mentioned, we don't know what's going to happen with the airlines, et cetera. Here, what we've done with some of our staff is if you do receive the vaccine, take your card and laminate it and just hold on to it in a safe place because we're not sure.
Okay, thank you.
Chris, there's a question inside of the chat. I'm just going to read that. It says, I know the second dose is meant to be a certain amount of days after the first. Is there a window where they have to get the second dose in a certain amount of time? And are people guaranteed the second dose if they've gotten the first? The only response that I can give you is in relation to TidalHealth. When you get your first shot, they're actually going to sign you up for the day that you're going to get your second shot. And so when you ask whether or not they're guaranteed a second dose, they're guaranteed a second appointment. We believe that we're going to have the supply for that. I don't want to put too much worry into this, but we do have to get the supply to be able to give you the shot. I do not believe that problem has happened yet. But it is definitely on our radar that we're making sure that we're making appointments for people and making sure to the best of our ability that they have that second shot.
And that is correct. I know in the state of Delaware, there is some discussions at the state level that they will only allow the first shot and not guarantee the second. But Bob's correct. TidalHealth has taken the stance that you will get. We're going to try our best and schedule you at that time. And when the doses do come in, we do allocate to the second shot, and nowadays it's minimizing the amount of first shots we can offer.
Yep.
So
if I can add it.
It won't matter if you're supposed to get it 28 days after the first shot. Like if you end up getting it 60 days after the first shot, it won't be less effective or anything like that.
The only way to answer that question right this second is to suggest that there is no data. I'm not saying that it isn't or is. I'm just saying that that's not the way the research was done. So nobody can provide you with assurance because that's not the way the research was done. I know that's not fulfilling, but it just happens to be the truth.
So if somebody who received dose 1 and never receives dose 2, is there any information on that? So you're protected half, you get half the proteins?
With the information that I know in regards to the Moderna and the Pfizer vaccine, is the belief is that about 10 to 14 days after the first dose, you're about 80% protected. When you get the second dose, you're about 95% protected. So, so in regards to that, getting the first dose, yes, is definitely important. And you should get the second dose, but if by chance something happens and you don't get a second dose, there is some protection provided by the first dose.
Okay, and just so I understand also, so the vaccine is protection to, if you were to get COVID, you would get a less severe version of it? Is that, so it doesn't exempt you?
I am so happy that you answered that exactly that way.
Okay, that just in layman's terms, is
so
that what I understand?
There is no switch, right? There is no yes or no to this. The switch is this idea that In the Moderna and the Pfizer vaccine specifically, those that receive the second dose, in none of them, or I'll just say it that way, and none of them were individuals that had severe COVID. And so, yes, it provides a protection, and that protection is based on how severe that COVID is. You may never get it, but it doesn't perfectly protect you from never getting it.
Okay, thank you. That's what I understood.
Yeah.
I think there's a misconception out there just in the world that it's, it's like you get the vaccine, both doses, and you will not get COVID.
It's a bit, I mean, it's along the same lines as the flu shot. You should get your flu vaccine too. And, some people, I've heard people complain in the past that, I got the flu shot last year and I still got the flu, right? But what they didn't get is the flu that put them in the hospital.
Okay, correct. Yes. Okay, great. Thank you.
You're welcome.
I had one more question, and sorry if you already answered this. I joined a little late. My question is I've had a lot of people, or I've read a lot online that the second dose of the vaccine has worse side effects than the first. Is there a difference between the two vaccines? Is one stronger than the next? And again, I'm sorry if you already answered this.
I did not. So the first dose sort of primes your immune system, and it gets your body to produce some antibodies against it. And you can think of the immune system at that point as being lay in waiting for when it's going to see it again. And so when it sees it, no, there's no difference between the two shots. But when the immune system sees those spike proteins again, it comes out more vigorously. And that actually means that it's working. And when I say more vigorously, I'm not talking about it puts you, it puts you in bed for a week or anything like that. All of the experience that I've seen are people who complain of sore arms, maybe some achiness, some tiredness. And in each one of those cases, it's solved by Tylenol and Motrin. And it's really important to know that within about 48 hours, those symptoms are just gone.
Yeah, that's true. I've seen on here my division of people I supervise, everything from just a sore arm to headaches to extreme tiredness. But the next day you feel like a new person. You're completely refreshed.
Great, thank you.
Okay.
Well, we want to thank everybody for the opportunity to share some information. If Bill has any further information, people can work through the Dorchester Chamber of Commerce, and we'd be happy to answer any questions even post this discussion.
Yeah. Hey, Chris and Dr. Joyner, thank you very much. It's very, very informative. Like I said, we will get this video up and posted. If you shoot me your slides, I'll get those out with them as well. And again, if you guys have any additional questions, feel free to shoot them to us here. We can route them over and get you answers back. And I appreciate you guys attending today.
Thanks, Bill.
All right, guys.
Very
Thanks,
nice
and have a
talking
good
to
day.
everyone.
All right, take care all.
Thank you. Bye-bye.